I'm starting the timer, and here is your question. Right. So if you have read and understood, kindly begin your examination session now.
Yes, I am ready, ma'am. Good morning. I'm Mr. Al-Ghaziri, one of surgical doctors here. Can I confirm your name and age, please?
I'm Marcus, 21 years old.
Hi, Marcus. I will start by washing my hand. Today, I'm going to examine your knees. It will include look, feel, and movement, and asking you to walk, and may arrange some special tests. Do you agree with this?
Yes.
Do you have any pain at the moment?
Little, yes.
Do you have?
Yes, not too much, but yes, I have.
Are you in need to prescribe any analgesia before starting examination or not yet?
No, that's all right. You can examine.
Okay, so I will try to be gentle as much as I can. If you experience any pain, let me know and I will stop. Okay. So initially, I will examine you. Please roll up your short, please.
Okay.
Now we will start by asking you, do you use any walking aids, please?
Yes, these days. I can't walk without it.
Okay, so are you able to do examination with me without aids?
Okay, I'll try my best.
Okay, thank you for your aid. Then I will start by ask you, can you take few steps to the wall of the room, please?
Okay.
Then turn around and come again. Okay.
All right.
Yes, thank you. Stand for me, please. I will take a close look after kneel down to your knees. Can you now? I will look for you. I will search for any abnormal gait in form of antalgic gait. Then I will search for scars, asymmetry, deformity, and by looking 90-degree one by one, I will see for any swelling or any scar or any signs of inflammation or ecchymosis due to trauma or swelling or discrepancy between the two knees or presence malalignment for previous fracture or so on. Okay.
Yes.
So now, if you don't mind, can you lean down on the couch, please?
Yes.
So now I will feel your knees. It may be, I will try to be gentle. So I will ask the patient, I will start to feel your knees. I will start firstly by temperature, comparison the knees with the above and down area and medial and lateral side, comparison with the other side to detect any discrepancy in temperature between the right and left knees. And then we'll search for tenderness. And we'll ask the patient told me if there is any tenderness or pain. I will start by feeling the patella, and I will look at the face of the patient, lateral and medial border, both lower part of the femur and the head of the fibula and tibia, tibial tuberosity, and joint lines, medial and lateral, including lateral and medial collateral ligament. Now I will ask the patient that I will take the weight of your knees to feel deeply your popliteal fossa, the knees, to search for any swelling in the popliteal fossa and
Good.
I will do this in the normal or sound side in comparison to the diseased side.
Good.
This is according to the tenderness. As regard, I will now take some measurement, including the quadriceps muscle circumference, starting by 20 centimeter above the tibial tuberosity, comparison the right side with the left side to assess any muscle wasting of the side. After that, I will search for any effusion of the knee joint. We'll starting by Paget test or patellar test. I will start by squeezing from up, then we'll tap with my thumb on the patella, floating or not, both sides. If there is no effusion, I will go for brush test or sweep test from the medial side and from the lateral side, and we'll look for sweeping or displacement of the fluid from the lateral side to the medial side or from the medial side to the lateral side. This according to the field. After that, I will ask the patient that we will do some movements passively. I will ask the patient to, can you bend your knees as much as you can by bring your heel toward the bottom, then straighten it. And I will I will ask about any tenderness for extension and for flexion and the other side. Then I will ask the patient, I will do by myself, but let your leg floppy as much as you can. And I will feel by, will bend and extend, will feel by my left hand, any click or crepitus in the knees. And I will search for any flexion deformity. After that, I will do some special test in form of an anterior dural test and posterior dural test in form of 90 degree and support with my elbow, the foot, and I will take both my thumb and the tibial tuberosity.
Can you please present your case now? Well,
yes, today I will thank the patient.
Yes.
You can rest now. I will pass my notes to my consultant to figure out your issue. Yes. I started the examination, 21-year-old male patient who presented with the right knee swelling.
Yes.
After football player. On examination, the patient is with antalgic gait and there is tenderness along the medial side of the knees. With no swelling or asymmetry or muscle fasciculation or wasting, but as regarded normal temperature and the normal quadriceps circumference. Special test, I started by anti-drawer and posterior drawer. To complete my examination, I will order also valgus and varus test, McMorris test, to detect meniscus injury or collateral ligament injury. To complete my examination, I will do joint above joint blue and complete neurovascular examination of the lower limb.
So what are your differential diagnoses?
So my main differential diagnosis, according to the trauma, may be medial collateral ligament injury, medial meniscus injury, but I will consider other cruciate ligament injury due to the swelling presented in the station. Or combination including bone deformity.
All right. Can you please tell me what investigations would you perform for this patient?
We will arrange some investigation lab and radiology, but I will start by the most important in form of X-ray knee, AB and weight bearing, to detect
not weight bearing because it's a sports injury.
Yes, and not weight bearing, AB and lateral. Also, I will order MRI. But after resolution of the edema, to avoid any heaviness. Yes.
Why would you do MRI? To rule out
MRI to detect any presence, any effusion or meniscus injury in form of increased internal intensity or occlusionicity of the meniscus or abnormal shape of the meniscus.
Just suppose there is meniscus injury. How would you manage this patient? Associated meniscus injury, yes or dear?
Yes, I will start already by rest for the patient, assessing with crutches or not, ice packing. Then I will, the most important, alleviate the pain in form of paracetamol or non-steroidal, considering GIT irritation, elevation of the leg, to decrease the edema or signs of the inflammation.
Yes.
Then after that, depending on the radiology, I will assess for either repair of the meniscus or meniscectomy, surgical treatment.
Very good. Okay. Yes, that is the, okay. Yeah. All right. When would you suggest the patient will be able to play the match again? What would you advise?
According to the match, as regarded now, it's not suitable. No. At least after resolution of the recovery of the knees, not before 9 months. Okay. Not before 9 months.
Good. Thank you. Yes.
Thank you, ma'am. Thank you.
Thank you. Right. And here is your question. Right. If you have read and understood, considering it critical care scenario, please tell me how would you manage this patient?
Yes, I will manage this patient according to the critical care of surgical patient protocol by maintaining patent airway.
Okay.
And I will talk to the patient if he talks this he has patent airway, and then by proper breathing, maintaining proper breathing, I will he has a respiratory rate 30, which is high, so I will assess if there is any I look for any abnormal movement of his chest with breathing. If there is any abnormal sound, I will heal for any abnormal sound like wheezy or and then I will percuss for hyper resonance or dullness. Then I will
patient is feeling chest pain and feeling tightness around the chest, and there is shortness of breath as well. So what would you do? What would be your immediate mode of action?
Will be needle thoracostomy.
Okay.
In the
where?
Fifth,
in which area?
Space, in the fifth intercostal space, just anterior to the mid-axillary line.
Yes.
Then I will put do thoracotomy in the fifth intercostal space, axillary line.
Can you please tell me what has happened to the patient while central line was being inserted?
Yes, the patient after having a central line, there is injury to the apex of the pleura.
Yes.
Causing lead to pneumothorax.
Okay, what are the different types of pneumothorax that you know?
There is simple and tension pneumothorax, open and closed, and primary and secondary.
Okay, can you please tell me how would you differentiate between simple and tension pneumothorax?
Yes, in tension pneumothorax, there will be deviation of the trachea to the opposite sides. There will be tachycardia and hypoxia.
Yes.
And there will be a one-way valve for a continuous air entry.
Okay, what how central line should be inserted according to the NICE guidelines?
Central line?
Yes, how it should have been inserted according to NICE guidelines?
Yes, the insertion should be done under the ultrasound
Very
guide.
good. Yes. Where?
And it should be positioned in the tip of
safe triangle. Can you
what?
please tell in the safe triangle? Can you please tell me the boundaries of the safe triangle?
Safe triangle for the chest tube?
Yes.
Not for the line. Okay, for the chest tube, anteriorly is the posterior border of the pectoralis major, and posterior is the mid-axillary line or anterior border of latissimus for dorsi, and inferiorly is a line drawn from the nipple back to the vertebra.
Okay, can you name few indications when central line should be inserted?
Yes, for central line for giving for parenteral feeding, and for cardiac pacing, and if there is for difficulty for giving peripheral line.
Yes. Okay, what are the complications of central line insertion?
Complications may be infection, sepsis.
One is immediate pneumothorax, and then?
Yes, immediate pneumothorax, hemothorax, infection, sepsis, and dislodgement from the place.
Yes, if there is sepsis, how would you manage the patient?
Oh, and also chylothorax. If there is sepsis?
Yes, please. How would you manage the patient?
Yes, I will. If there is, I will give the patients. I will monitor for the fluid and electrolytes, and start giving. If there is pus, I will do culture and drainage, culture and sensitivity, and giving antibiotic according to culture.
No, first you'll remove the central line, first
Yes.
thing, and then you'll send the blood cultures. You'll not start antibiotics right away. Okay. Can you please tell me what is the most common organism that you can find when there is infection?
Yes, staph epidermis.
Okay. What are the measures that you can take to prevent the infection?
What layers?
No, measures. What would you do? Yes, to prevent central line infection to happen? Yes.
Yes, perform a good proper hand hygiene.
Yes.
Before handling with the line, and apply an appropriate skin antiseptic.
Yes.
And ensure that the antiseptic agent or the preparator agents are dried before inserting the central line. I should use the sterile gloves and put a cap and the sterile gown and wear a mask and use a sterile drape. And that's all. And wash my hands before and after.
Yes, and you remove the central line as soon as it's not needed.
Once it's no longer needed, you move
yes.
to decrease the chance of infection.
All right. Can you please tell me what investigations would you do to confirm your suspicion of pneumothorax?
Just X-ray.
And anything else? Because patient has shortness of breath. Maybe ABGs?
Yes, ABG, pulmonary function test.
Can you please help me and read this X-ray? Can you tell me how would you read the X-ray? What can you see?
Yes,
like
I will
A, B, C, D, yes.
Yes, I will look. There is for the airway. First, the trachea is deviated to the right side, and there is what is it?
And anything else?
Okay. Airway, bones. Their bones are.
Do you think this X-ray is enough for you to look at the enough for the estimation of your case of your patient for the evaluation? Is it giving you enough information about patient's situation? Yes.
The central the line is not centralized inside.
Here also you can't see the bottom.
There is no there is ill-defined costophronic angle.
Yes. And anything else?
The heart.
Yes. What about heart? Doesn't it seem to be in the chest?
What?
Doesn't it seem to be in the chest? Maybe there is diaphragmatic hernia or something.
Yes.
Fundus is there. Yes.
It's abnormal, but I can't detect abnormality here.
Good. Thank you.
X-ray.
Yes.
We need to comment according to mnemonic A, according to the airway.
Yes.
The airway air in the trachea is shifted to the left side. Yes. And according to the bone, there is scoliosis of the thoracic part of the vertebral column.
Yes.
To the right side.
Yes.
And according to C, the cardiac shadow, the apex of the upper part of great vessels of the heart may little bit shifted to the left side, but obscured with hollow viscous shadow on the left side.
Yes.
And according to diaphragm, the field is not equal to visualize the diaphragm is not visualized clearly. No. And according to the finding of the X-ray, yes. It showed what we call the jet black like shadow in the right hemithorax with collapse of the right lung. Yes. And we also can comment on the gastric bubbles must be visualized, but after insertion of the nasogastric tube to visualize the site or the location of the stomach. And we also can comment on the other technical in form of that there are 9 pairs of posterior ribs is visualized, 2 apices and thoracic spine visualization.
Very good.
But this, yes, this is according X-ray.
Very good. Yes, Dr. Hamdi, is it clear now?
Yes, trachea to the left or right?
Right.
Trachea to the right?
Shift the trachea to the left side.
Left?
The stomach is the left side. The trachea shifted to the same side of the stomach, to the same side of the heart.
Okay, and what is the diagnosis of for the chest X-ray?
Maybe the diaphragmatic hernia, but can't be confident about this diagnosis until we do the same X-ray with nasogastric tube to visualize transection of the nasogastric tube to the carina and at least 10 centimeters below the diaphragm.
But it's not pneumothorax, right?
There is pneumothorax. The right side is pneumothorax.
Pneumothorax, okay.
Oh, thanks. Okay, I'll show you this I got from Google. Yes, thank you. All right, here is the question. Right. If you have read and understood, considering the
Yes,
surgical
ready, ma'am.
administration, can you
Yes.
please tell me how many, what are you looking at here? What are these?
Is the diploic spaces?
Okay. What does it show? What are diploic veins? What are diploic veins?
What is the question, please?
What are the diploic veins?
Diploic veins is veins that drain the diploic space of the skull.
Okay. Can you please tell me if you can identify all these structures from 1 to 8?
Yes.
Please.
1 is confluence of the sinus.
Okay.
2 is straight sinus.
Okay.
3 is inferior sagittal sinus.
4.
4 is the sigmoid sinus.
Yes. And then 5.
5 is inferior petrosal sinus. 6 is
6.
superior petrosal sinus.
Yes. 7.
7 is cavernous sinus.
8.
8 is sphenoparatile sinus.
Okay. Can you please tell me how many venous sinuses there are altogether?
Altogether
Yes,
is
please.
4,
How
4
would you...
single and
Yes.
6 pair.
Very good. Okay. Can you name them all, please?
Name: superior sagittal sinus, inferior sagittal sinus, straight sinus, occipital sinus.
How inferior sagittal sinus is formed?
In the superior border of pharynx cerebri.
Okay, and it runs from medial part of cerebral hemisphere to
the confluence of the sinus.
To straight sinus. Okay, and the straight sinus, it is formed by, if you can tell me quickly all the sinuses.
Straight sinus.
Yes,
come
please.
from
Yes.
great vein.
So it runs from superior border of tantrum cerebri to, yes, from great cerebral vein, inferior sagittal sinus
to confluence of the sinus.
Very good, very good. Okay, can you please tell me what is cavernous sinus?
Cavernous sinus, it's a venous sinus that is present. Two cavernous sinus present in both sides of the pituitary fossa or sella turcica.
Yes.
That drain venous drainage from the dangerous area of the face through the facial vein and ophthalmic veins, especially the inferior one. Then drain to the intercavernous sinus and the superior and inferior petrosal till sigmoid sinus.
Okay. What are the structures which are contained in the
within the cavernous sinus, within itself, within carotid artery and abducent nerve, and in the lateral wall will be tracheal, oculomotor nerve and trigeminal nerve, maxillary and mandibular division.
Very good. Okay, very good. All right. Can you please tell me how the sigmoid, why sigmoid sinus is called sigmoid sinus?
How sigmoid sinus is nominated as sigmoid?
Yes. Why is it called sigmoid sinus? Yes.
Due to the tortuous course or the curved course of it.
Yes.
So it's called sigmoid sinus?
Yes, good. Okay, right. I asked you, can you please tell me how a patient can present with papilledema? Because in this case, patient had CSF rhinorrhea. And if CSF rhinorrhea, so, and there is also periorbital swelling. So can you please tell me what is the mechanism behind papilledema?
The mechanism of what edema? Periorbital edema?
Yes, papilledema. Yes, periorbital edema.
Due to the fracture base of the skull?
And
the impairment of the venous drainage of the communication with cavernous sinus draining the eye.
There is something more about the optic nerve sheath. What about it? Can you please tell me what happens?
No, can you buzz this question, please?
Okay, all right. Can you tell me what is the structures lateral to anterior clinoid process?
Lateral to the anterior columnoid process.
Yes. Okay,
Inferior
can you?
orbital pressure.
No. Can you please tell me what are the optic canal and what are the structures which pass through it?
Optic canal transmit optic nerve,
Yes.
ophthalmic artery, and the sympathetic nerves.
Okay. Can you please tell me what are the site of trigeminal ganglia?
Near to tegment tympani.
And? There is more, you have to read, please. Okay,
Yes.
can you please tell me what are the risk factors which lead to cavernous sinus thrombosis?
Infection in the dangerous site of the face draining by cavernous sinus due to with presence of valvulus veins leading to retrograde spread of the infection into the cavernous sinus.
Can you name few like nasal furuncle, sphenoidal or ethmoidal sinusitis, and dental infection? Okay, what are the clinical features? How would a patient present with?
Yes, the patient will be presented by painful swelling of the eye.
Yes.
Ophthalmoplegia, including 3, 4, 5, 6 cranial nerves affection and the gradual loss of the vision.
Okay, good. In this case, just imagine patient has base of skull fracture. Can you please tell me how would the spread of infection takes place?
Spread of the infection due to fracture base of the skull
Yes.
may occur due to mastoiditis and the erosion of the bone or spread of the ethmoidal mastoid air cells and the infection to the brain.
How? Travels through?
It's through CSF leak.
Okay. What is the site of middle ear cavity?
Middle ear cavity.
Yes,
it's related to the middle cranial fossa.
Yes, but
separated
site.
by tegment tympani.
Yes, and between temporal bone, between eustachian tube and auditory canal.
Yes, this is like a box, like cavity, separated middle cranial fossa superior and anterior from the eustachian tube or tympanic tube.
Can you please tell me where ethmoid sinus is located?
In both sides of the nasal septum.
Ethmoid sinus. No. Okay. Can you tell me what is optic chiasma? Last question, please.
Optic chiasma, these fibers that crossed from the lateral side to the medial side and from the medial side and responsible for formation of the optic nerve. It is present above the pituitary fossa.
Okay. Can you please tell me what exact structure is the cranial nerve 3 is pressed against? You
Nerve
can be asked, yes, third nerve. It is pressed against, yes. On the prosection, they can ask you to point it out, or on the model, they can ask you to point it out and show.
The third cranial nerve against the attached border of pharynx cerebelli.
Okay, what do you get when there is increased intracranial pressure or raised?
Yes, according to increased intracranial pressure, the most affected nerve is abducent nerve, and the patient will be defect in the downward lateral gaze.
Yes.
What's called full localizing sign.
Yes. Okay, good. Thank you.
Thank you. Thank you, ma'am.
We can just confirm once all the vessels, all the you told me. One is superior sagittal sinus, 2 was straight sinus, 3 was great cerebral vein, yes. 4 is sigmoid sinus, and then 5 here is inferior petrosal sinus, 6 is superior petrosal sinus, yes. 7 is cavernous sinus, and 8 is pneumothorax sinus. Yes. So you can have a look at the solution as well. Maybe I should highlight them and then put them so you know, because some extra are given here as well. This one. Good. Thank you.
Thank you, ma'am.